so she presented with the chief complaints of cough and fever and abdominal pain, vomiting for around 10 days. On presentation, she had low-grade fever. Physical exam was notable for left-sided abdominal pain. Basic labs, including the CBC and the BMP, were with a normal. Chest X-ray also was unremarkable. Patient was managed mainly with supportive treatment, and her fever and cough gradually continued to subside. However, her abdominal pain persisted, so we went ahead and did a CTA of the abdomen, and surprisingly, it showed the hypoattenuations in the spleen, like as shown on the right side of the screen, that were suggestive of splenic infarcts. So the patient was started on therapeutic heparin, and further workup to detect any coagulation disorders for this patient were done. This were including protein C and S levels and factor V Leiden mutations, which all were unremarkable. However, she did have slightly elevated antiphospholipid antibodies, including anticardiolipin and lupus anticoagulants. Patient was then discharged on oral apixaban, and she completed a total duration of treatment of 6 months. During that period, she followed up with the hematology clinic just to confirm the absence of other underlying causes that might have caused these thromboses. And her levels of anticardiolipins and antiphospholipid antibodies were repeated, and they were normalized after a few weeks. So basically, this is a case of CMV-induced thrombosis, and why we think that it was induced by CMV is absence of any other obvious causes. And also, even if we thought about antiphospholipid antibody syndrome, she did not typically fit the picture, whether clinically or with lab factors. There have been multiple theories proposed on how viruses and how CMV induces thrombosis, and among these was direct endothelial injury or platelet aggregation. In our case, the actual induction of a transient elevation of antiphospholipid antibodies might play a role in how these viruses will induce thrombosis. A couple of learning points here is that a CMV virus can cause serious complications, though rarely, but it can cause complications in immunocompetent patients, as in our patient who did not have any significant issues or past medical history. Another point is that to raise awareness or put it in among our differentials when a patient has symptoms of viral infection along with detected thrombosis, CMV could be considered as one of the triggers for this thrombosis.